for 26 years, hard to believe. And among his students include Josh Gordon, who's the current head of NIMH. Gerry is a practicing psychopharmacologist and a neuropsychologist in private practice in New York. He concentrates on, regretfully, treating some of the most complicated cases, and today is going to share some insights to how sleep is a factor everywhere and how it can be applied in almost every type of health solution. So Gerry, please.
Good morning, everybody.
Good morning.
Good? Yeah.
No.
No, your mic is not working. My mic's not working. Is it working better now? No?
What should we do?
Oh, I hear.
How about now?
Yes.
How about now? Okay. Anyway, I'm really pleased to be here this morning, and I especially like that very stimulating conversation that came before me, and all the others. I thought I would go back to a comment that John Madison made yesterday about the different ontologies, the incommensurability, or anyway, the problematic commensurability of some of the different ontologies. And among other things, I have a master's degree in philosophy, so I hear ontologies, I'm thinking the pre-Socratics and Heidegger. But I realized then, as I changed my, I think we used to use the word paradigm for that. And now we use ontology, which is a very interesting word because it implies that the way in which you look at a phenomenon and complex, human behavior obviously is a complex phenomenon. Depending on how you look at it, you're going to see different things, like the famous story about the Sufis who look at an elephant, the blind Sufis, and one thinks it's a snake and one thinks it's a tree, etc. Your perspective and your viewpoint has a great bearing on how effective you are. How much you understand of what you're seeing. There could be more than one way of understanding, but also how effective you might be. So I think the whole topic of circadian rhythms is a particularly challenging and interesting angle on the human condition. And what I mean by that is, and sleep as obviously part of that, is something that's ubiquitous. We really don't understand it very well. And we don't really much engage in thinking about the circadian rhythm in life, despite its ubiquity. As I decided to put together this talk today, I thought, well, rather than try to say to you, oh, here's a brave new way to look at circadian rhythms, I thought rather I'd like to challenge everyone in the audience to look at the science, and I'm going to give you some pretty rigorous science. I'll make it as fun as I can. Some fairly rigorous science, but I'd like you to think, how can what I want to do in the technology area, how can what I want to do take a hold of the problem from this circadian paradigm or circadian ontology? So I wanted to start by saying, well, if you want to talk about ontology or phylogeny, this is a very cool fact. Circadian rhythms go back to the very start of organisms on the Earth. So this is an old problem. It goes back for a while. They didn't have access, these plankton didn't have access to the monitors we have now, but they do engage in a cyclical metabolic dynamic that involves the 24-hour day-night cycle. The 24-hour day-night cycle affects all of the energy and the energy throughput of organisms on the Earth. And although I'm not an expert on this, I will go so far as to say that I think without that rhythm, the cyclical rhythm of the Earth day-night, 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 a lot of evolution and a lot of development of organisms on the Earth would not have gone the way it does. And so to begin with, I'm going to try to use that as a way to explain what I mean by a circadian pump. Because we're not just exposed to the radiant energy of the sun 24/7. It wouldn't even be a 24, by the way, right? I forgot about that. There wouldn't be a 24. If we only had sunlight all the time, and we did not have that on-off of the circling of the Earth, this sort of pump feature that I'm going to try to elaborate more in the realm of behavior may not have been available to us and to all of development going back to before there was Facebook. Okay, so I'm going to try to make this pretty straightforward and easy. We're not going to go into a great deal of science about it, but this is a model that you see displayed here. I'm going to break briefly. I don't need a microphone. This is an important model that it's not a new one. It's been around for some time, but it shows that there are two different systems for our 24-hour day-night cycle. So the one is called process C, that's on the bottom, and the other is process S. I hate when they give them nondescript letters because then you have to memorize what they stand for. But essentially, process S is not, strictly speaking, a circadian, it's not a physiological circadian rhythm. Rather, that's what happens when we go through the day and we engage in our activities, and it costs us energy. We accumulate information. We use up energy to accumulate it because we need energy to store it. And our brain temperature actually rises over that time, almost certainly in part because of those factors. There are others too, I'm sure, but the amount of information we're taking in has a lot to do with the diurnal, the circadian rhythm of temperature being highest at night. And that process S is thought to involve the buildup of some chemicals. Many people think it's adenosine. Adenosine is what we block when we drink caffeine, by the way, because our adenosine level is going up during the day. It's making us drowsy. Caffeine blocks it. The adenosine rises, we think, among other factors, and it plays a role in this process S. And then by the end of the day, as it's accumulated to a certain critical threshold, it makes us sleepy. Now that is really a behavioral component of, I guess, what you'd call circadian rhythm, because it really has to do with more what our behavior is. It's not, per se, that's not a physiological thing. That's our being active and building up using our energy the way we do, and building up the adenosine. The process in the bottoms is more like the what we're thinking of as a physiological circadian rhythm. That is, there are several rhythms in our body. They seem to be coordinated by the suprachiasmatic nucleus in the hypothalamus, and it sets that rhythm, hopefully for many of the organs in our body and all the cells in our body, and that's what establishes our 24-hour rhythm, okay? Now, the thing about it is that the rhythm can be affected. Its phase can be affected. So in other words, you might find yourself going to bed later and later and later, so your phase is shifted. Or its period can get longer or shorter. So it's hard to fit your activity in one day because you're, and of course everyone knows jet lag plays some role in this also. That's what jet lag is. It's when that rhythm breaks with the top process S. And its amplitude can affect. So what do I mean? Well, so for example, body temperature being one of several, I'm going to mention some other circadian, physiological circadian rhythms. The temperature variation from day to day, which is usually around 1 centigrade, it can be blunted, so the amplitude is more dampened, or it can be exaggerated. Okay?
Excuse me, I'm so sorry, but there's a lot of scratch on your mic. Can you relocate it?
I will do that. Oh, I think it's because of this let me take this off. I think you've all identified me. I am who I say I am. And you know what? I think I'm going to put it around this way. Thank you for saying something. How's that? Better? Or I should say, how's that? Is that okay, so, okay, this is getting, the slides are going to get a little bit more complicated, but again, I'm going to make it easy and simple and say the most important thing. So, so the question you might ask is, so what are circadian rhythms for? Okay, well that's the wrong question. Why did you ask that question? That's not really right. I told you that circadian rhythms are, I mean, plankton have them and bacteria have them. So it's kind of an odd question, what are circadian rhythms for? Because they just definitely do exist. I guess a better way to say it that makes sense of the question is, How did our bodies and then of course by extension our behaviors adapt to the circadian rhythms, and what do we get for it? Did the adaptation over millions of years, literally, and over the last couple 100,000 of years for humans, did that adaptation get anything out of the fact that we have to be exposed to this day-night cycle? So there's a theory that's been promoted for some time by Giulio Tononi, where the notion is, and this is where the idea of a pump for mental health comes into play. And the idea is that during the day you are storing up information. It costs energy to store that information. This is stuff that's usually, first of all, localized around the hippocampus in the brain. It has some extensions beyond that to cortical areas, but we think long-term potentiation and long-term depression have a lot to do with that, the buildup of those connections. But it costs. It's energetically costly. And then what happens at night, we believe, is that you offload those memories, those highly energetically costly energies, to cortical areas where it's stored into long-term memory at lower energetic costs. So now we've got gene products and such that seem to establish engrams, they're called, in the cortical areas of your brain. That's where you store your long-term memories. And it seems those are less energetically demanding. So we can cycle through every day, build up, use these as energy costs, space costs in the hippocampus. It gets saturated over the day, and at night your receptors get set back to, let's say they're zeroed, back to zero. You know, obviously it's not exactly that, but they're lowered again. And you're ready for the next day. Meanwhile, your information's been offloaded to a more efficient storage. So this is a model that I've actually developed, and I use basically per Tononi that I've developed and that I use. Believe it or not, thermodynamics is not normally involved in patient care. But actually, I think this, you'll see, this is an instantiation of what I just described to you by Tononi. So during the day, our brains are sort of open for business. We're absorbing information. We're forming connections. And it causes an increase in entropy. So your system's building out and becoming complex. And meanwhile, there's a lot of energy cost involved. And by the end of the day, as I mentioned earlier, your body temperature has reached a maximum, typically. And then at night, your brain will reset those receptors to zero. And it actually releases heat. And it's interesting to note that people do, shortly after falling asleep, drop about a degree temperature pretty quickly after sleep. Kids do it even more than adults. And that explains why a lot of kids, it's very cute. Well, it's usually cute. Anyway, it was cute when my kids did it. You know, they'll be sweating. You can see that they're sweating in an hour or so after they fall asleep because they're shedding heat during that time. So the accumulation of waking energy is energetically costly during the day. These traces are meant to be quasi-temporary. And at the end of the day, you've reached a sort of maximum entropy state. And it's an interesting thing because we often think of information as being the negative of entropy. But you know, when we're exposed to life, there's a lot of noise and a lot of information, and that actually does build to a high level of entropy. But then when we zero those receptors, when we offload it, it's sent to the cortex more or less, and you've got a fresh brain for the next day. And it's not, in the next slide you'll see I refer to, or a slide or two ahead, oh no, this one, WM is working memory. Working memory is a part of that short-term storage that happens during the day that I say is mostly hippocampus focused and involves long-term potentiation. So I think this is a picture of mental health, probably a picture of physical health. And what I mean is, during the day, this is an idealistic, stylized and idealistic version of it, but during the day you're sort of maximally alert, ideally alert, there's a dip after lunch or for boring lectures unlike others you'll see today. And then at night you get a good night's sleep, you sleep deeply, the memories get offloaded, they get consolidated, because that's where we think most of memory consolidation happens, not exclusively, it happens during the day also, but with practice, interestingly, when we practice things, we consolidate memories. And then during the next day, we've cycled back up. So what I tell my patients is that red arrow that I have here, that is, it's almost like a physics thing. That's the potential energy you have for your day. So if you've got a good night's sleep, and you've got a good night's activity, rather, alert, engaged, ideally engaged, stimulated, physically active, and then you have a correspondingly deep night of sleep, that space, that amplitude of your circadian rhythm is, we'll say, maximum, and that is the amount of energy, the useful mental energy you have for your next day. So, constructive planning, goal-directed activity, and adaptability and resilience. This is what you want. So if your new circuits are ready for action, you know, they've been cleared of all yesterday's activity, or largely cleared of it, you're ready to take on the new day and engage in a very, you know, adaptable, flexible, plastic sort of way. This slide shows you what people who have mental illness look like. It's mostly people with depression and anxiety. I don't want to say it applies to every sort of illness. Schizophrenia, for example, is an autism or I don't yet want to apply this model to those, but I will say that for the more common mental illnesses like mood and anxiety disorders and bipolar and PTSD, this pattern really applies, and that is, you'll see during the day, there's a dip into sleep, you might take a nap, you might be just good for nothing, you may be alert, but your mind really can't think or concentrate, then it goes back up, and then you have a little micro sleep in the middle of the evening, and then you fall asleep, and then you wake up, and so there's intrusions of sleep into the daytime, and there's intrusions of waking into the nighttime, and so the amplitude of this beautiful behavioral rhythm is damp. It's dampened, and so you see that arrow, the corresponding arrow, is small, and that means you don't have a lot of working memory space and other adaptability spaces. Working memory is just one of the things. Working memory, is how many things you can keep in your mind at once and things of that nature. So, but all the short-term things that you want to be flexible and sort of plastic in your thinking, you're not good for that. So you have much less of reserve to apply your thoughts to what you need to be challenged to do, and so because planning things and organizing things requires not only energy, mental energy, but it requires the ability for the energy to be distributed properly. I need that for that, I need this for that, I'm going to wait, I'm not going to do that now. That's these sort of executive functioning features, and when you have such a shallow amplitude, you don't have that kind of reserve. And what you get is anxiety, agitation, ruminations. So ruminations, of course, are really, everyone knows this, the sort of pointless loops of thought. They're not doing work. Right? What's work? I have a thought, I make a plan, I enact it. That's mental work. And it's like physical work. I mean like physical work in physics. And you don't have that when you have this very shallow amplitude. Okay, so let me pause for a second. What does this mean in terms of behavioral interventions? So here's one of the entry points for people who are interested in stimulating behavior, getting people to sleep better, getting people to take more steps during the day, get physically active. I really do put a premium on this for my patients. That is, I want them to be physically active within their ability, because some people are ill and they can't, or just the people who have the orthopedic surgery recently, they can't get up and they've got 3 months of convalescence. But to the best of the ability, physical activity is very important, and then mental activity is important. And it's interesting, I don't have yet, at this point, any sort of way to decide who needs how much mental activity versus physical. But I have to say I do think there are some people who benefit almost exclusively just from getting enough exercise. They don't need particularly challenging mental things. And other people primarily need to be really thinking and solving things and challenging themselves to do cognitive tasks, not as much physical. Usually it's some mixture of both. I like people physically active. I like them, thinking and doing things. It says something also about rehab, rehabbing people who are mentally ill. I really do try to push patients back into their work and their job early-ish. Look, I make a determination about it. The problem is if you put them back into early and you try to push them and make them go back to your old job, agitation could set in and they make a mess of it. This is why a lot of depressed people, we try to encourage depressed patients, family members, come on, get up, go for a walk, and they're like, I can't. Well, one of the things about that, and I think this would improve the problem with stigma, for people to have some empathy about this, is that oftentimes patients, if they are lying in bed and doing nothing while they're depressed, which I think most people agree is not that useful to them, if they do get up and go, they often get very agitated. And we have to bear that in mind. And it may need to be addressed. Insomnia, there are lots of studies that show that insomnia is big, that it's a big determinant of depression, anxiety, almost any mental mood or anxiety disorder, and also serious mental illness. It's associated very strongly with suicide attempts. Insomnia and nightmares, both. And this is just a small sampling of the things that that demonstrate that effect. Now I have a dolphin up here. Some of you may know that wonderful factoid that the dolphins sleep with one hemisphere while they're swimming with the other, right? Because they don't go to bed at night. So their brain can actually have sleep in one section and waking in the other. This is a really cool issue. There are these two conditions, ideas. One's called microsleep and one's local sleep. So microsleep is a problem for it gets most attention in the literature because we don't want people falling asleep at the wheel. And what we find is that many patients, drivers, for example, they can be awake and they do have these sort of micro intrusions of slow wave sleep. They basically fall asleep for anywhere from 3 seconds to 15 seconds, and unfortunately they're at risk for crashing. So there are a lot of different studies looking at how can you ID microsleep without having EEG leads on everyone's head while they're driving, right? So your head going down. The cars, incorporate some of this now. Is a person's head dipping? Do they have other signs of, less flexibility in their driving? So local sleep is an even cooler idea, and that is part of your brain, like the dolphins, but not half your hemisphere, because we don't seem to have that thing. But there's strong evidence now that there are little clusters of areas in the brain where sleep can set in while the rest of your brain's awake. And similarly, and this I think plays a role in nightmares and profound dreams, there's also this potential for local wakefulness during, or local arousal during sleep. And that can account for nightmares and broken sleep, obviously. And then finally, and I'll jump through this real quickly, waking, so based on what I just said, waking is not a unitary state. We're not only fully awake or fully asleep. We can have partial states. And this is also a very interesting area to look into. How can we figure out when someone is not fully awake, where most of their brain's awake and some of it's not, or briefly it's not awake? So wakefulness is not a unitary state. Orexin seems to be the master switch, but there are these, so orexin turns on all these other neurotransmitters. So that you have serotonin in the raphe nucleus, norepinephrine in the locus coeruleus, dopamine in the ventral tegmentum and substantia nigra, and acetylcholine mostly in hippocampus. These are more elaborate little nuclei. But in any case, if you understand this, someone could be awake, but their serotonin system or their norepinephrine system's not in sync with the rest of it. This is also relates to circadian rhythms. So the idea would be, I'll focus on one, dopamine. People are manic, They're very drowsy. They haven't slept in a few days or barely slept in a few days, and they're driven to do something new. And you may know that dopamine levels have something to do with novelty seeking and with reward expectation. So you have this problem, a very common problem, of patients who know they should go to sleep at night, and you're giving them medication to help them go to sleep at night, and they say, I don't know what it is. Just before bedtime, I decide I can do my laundry list, or I'm going to look at a rental for the summer, and people will get activated at night. And you can tell them you need sleep, and they don't typically listen. And it has to do with this sort of mismatch within the waking system, where one system is on high alert and the others are all shut down. This is the last technical slide, and we're going to move on to a little bit something more close to what we're all interested in here. This is just a very fancy system that describes the what are the components of that physiological clock. So these are gene products that have this very elaborate feedback system where BMAL and the clock genes combine. They affect other things which then have a feedback. They create these other gene products called PER and CRI1 and 2, and they turn off the BMAL clock. And so it's a really amazing sort of circular rhythm. The thing that's relevant here, and the only reason, aside from I want to impress you with the really elaborate neuroscience slide, is that there are medications and also behaviors that influence a few of the inputs to this elaborate system. I mean, the one that is uppermost in my mind, but it's just an example of several. And again, it would be a challenge for us all to discover what other things may be an input here. But there's an indication that this activity of the PER2 gene product might predict response, for example, to lithium in bipolar patients. And it's known that more traditional antidepressants, not just mood stabilizers, also play a role in these this sort of BMAL circadian. Okay, I think I got to the end of a lot of heavy science. As I was writing this, putting this together, I thought, oh, what are you talking about this whole time? Okay, so where does it fit in? What's the challenge to people who are trying to do what we're trying to do here, which is develop technologies and bring it to bear on this ontology of circadian rhythms that normally has been excluded from a lot of our attention? I mean, what can we do? And I have to say, I don't want to sound overly enthusiastic about it, because I think we've got a ways to go. I mean, I'm enthusiastic in the long term, but in the near term, I think we got a pretty big challenge ahead of us. But there are all of these different parameters that could be measured, and already some of them to some degree are being measured, that could play a role. So we've got body temperature, endocrine regulation, I guess the cortisol, prolactin, and melatonin. I think John Madison also mentioned yesterday how important, for example, some measurements of diabetes, which is down in metabolism, that the response to insulin and to feeding and et cetera needs to be indexed to the circadian rhythm. And it's something that isn't yet done regularly. Autonomic regulation, skin conductance, there are a lot of, and others, gut activity that also could be measured. And understand that sometimes the different components of the overall circadian rhythm can dissociate. So one has been very active, and again, like jet lag, your GI system may be in one rhythm and the rest of you is another rhythm, etc. The sleep-wake cycle is a natural. I'm going to skip over mood state because I want to make a point about that, and it's where our product plays an important role, just to be bluntly honest. But psychomotor activation is actigraphy, I would imagine. I was mentioning to some people yesterday that when I heard that actigraphy and and peripheral sleep evaluation was now available to us. You didn't have to send people to a sleep lab. There's an easy way to measure people's physical activity. This is going back a few years. I thought, well, we're going to solve bipolar disorder and mood disorder is going to be great. Well, it's been a little more complicated. The actigraphy literature has really not yet been sorted out, and it's really promising. But it's a little bit. It's one more level or two more levels of complexity than just let's measure actigraphy, and maybe this is where computer learning may play a role. because it's not a straightforward linear issue. Circadian clock indicators, well, attention and memory also are relevant. You know, there are tests we can give of the individual's attention, and that definitely goes through phases through the day. It's an important indication of a circadian rhythm, memory function as well. Circadian clock indicators goes back to my previous slide, where there are ways of assaying some of these clock genes. There's someone at the University of California, San Diego, Mike McCarthy, who's been doing a test measuring PER2 that's been, you know, labeled by a virus. Very cool. And but the technology needs to be advanced. Currently, you need skin fibroblasts, so you need to get a little skin scraping, and I think it has to be done a little too frequently. But we'll see. That's a technology that may be yet becoming, and I think some of the genetics people should take note. I think it's a really important area. So I highlight mood state because, look, for any one individual, there could be lots of ways to sort of put one of these things at the top. I mean, if you've got diabetes and you don't have a mood disorder, then clearly what you might want to do if you're looking at circadian rhythms is primarily focus on blood sugar and insulin response, and then everything else should follow from that. Like, that should be at the top. But I would like to think, I can make a strong case for this, I think, that mood disorders are really the foundation of everybody's overall physical health. And we know that depression and anxiety combined are the #1 cause of chronic disability in the world. I mean, there are very strong arguments that rather than putting mental health at the end, we should put it at the beginning, and that should be a lot of our focus. I'd like to suggest that in terms of circadian, understandings of the circadian ontology, tracking mood would be a great sort of lingua franca. That should be, everything should be compared, I submit, to that for the average patient. So we should look at these other parameters and see how do those other parameters fit in with the person's report of their mood and anxiety and so forth. So, the M3 checklist, just a quick point, it assesses 4 different major conditions. It probes for suicidal ideation, alcohol, substance abuse, functional impairment. Michael Byer mentioned this yesterday, that this is the questions we have about social and school and work functioning on the one hand, family and friend relations on the other. Very important also indicators of overall mental health, and that's included in the 27-question test. And not only that, but the M3 provides one single overall score for overall psychopathology. I think that's really important. And my final point, this is a picture of the report that LabCorp provides when it's given, the test is given, it's available through LabCorp. You see the 27 questions, the responses, an indication whether they're in range or out of range, and then in the bottom left, the risk for the 4 major mood and anxiety conditions. My last point relates to something really very interesting. So in our original validation study in 2010 at the University of North Carolina, Brad Gaines was the principal and investigator. The senior investigator was David Rubinow, who was then head of NIMH at the time. We validated against what's called the MINI, which is a standard clinician-rated diagnostic screen. So the M3 was rated against it. And what we found was we could identify depression as well as the PHQ-9, anxiety as well as the GAD, bipolar as well as the MDQ, which is a bipolar screen, and PTSD as well as the CAPS. And so as well as that we had very similar sensitivities and specificities to each of those single diagnostic screens. We have it all in one screen. But here's the cool thing about it, you know, the expression, the whole's greater than the sum of the parts. This was part of the statistics that was analyzed after the report was actually made. And what it was is we did this sort of regression analysis. What were the questions that were most highly correlated with a particular risk designation? And what you'll see is that for depression, it's not a big surprise. Sad mood, low energy, suicidal ideation, and anxiety were at the top. But right after that is nightmares. Nightmares, by the way, the question is actually nightmares or flashbacks. But I sure did to say nightmares. High up on the risk even though that's not traditionally, it's not a depression probe for most screens, and certainly not the PHQ-9. Under anxiety, look where nightmares appear. Also, the GAD-7 doesn't even ask about sleep, where nightmares. That's comparison, the GAD being an anxiety screen. Under bipolar, you see again, panic anxiety comes up second, bipolar, and nightmares, number 3. And for any diagnosis, now by the way, I don't have PTSD here, but because nightmares is a inclusion criterion for PTSD, it was number 1 for PTSD. For any diagnosis, so that if the overall M3 score is above a certain number, and you report a certain amount of functional difficulty, those patients who had any diagnosis, they get a number assigned, just like a cholesterol number. It's a single number of their overall symptom burden. Nightmares was number 2. And that, I think, is a wonderful, totally unanticipated. That was an interesting way in which we could demonstrate that there is this sort of synergy when you ask a broad enough range of symptoms. And I think with that, how's that? Wow, close. Thank you for your attention, and I'm happy to answer any questions.
What is
Anhedonia was the original name of the movie Annie Hall that Woody Allen made many years ago. And what it means is a lack of response to, that's true, it was. He was going to call it anhedonia. But it's a lack of response to normal pleasurable activities. And that's a strong indicator of depression. And also, interesting, bipolar disorder, because bipolar depressives in particular have that symptom.
So one of the things I've heard, and my name is Arthur Keller from Psychanalytics. One of the things I've heard is that people have different natural circadian rhythms. So if you didn't expose people to light, you put them in a cave, and so, or had light on all the time, their circadian rhythms might be less than 24 hours or more than 24 hours, and that night owls tend to have circadian rhythms more than 24 hours, and morning doves, if you will, tend to have morning larks tend to have circadian rhythms less than 24 hours. Can you expand on that and the correlation between that and the mental health issues?
I can't. You just said it. Because the implications of that finding have not been worked through. I mean, that's something that we, all of us, can play a role in developing, because it's sort of like this idea that I think it was my first slide is Worst Justice. I think Anne Worst Justice. She and her husband or her father have been doing work on circadian rhythms for like 30 years, and they're finding that circadian, the sort of natural. So that's the process C from that slide. That the natural underlying circadian rhythms might be either over short or over long, and that lithium, for example, in some of them corrects it. So you thought, oh great, we got that solved, and no, it never, so it's relevant for a subpopulation of patients. And it can be highly relevant for an important subpopulation, but we don't yet have a way of identifying it, clarifying it, of course measuring it, and getting a bead on the long circadian rhythms. The short ones would be a really great way to sort of start to understand it.
My work is in gerontology, and I find this quite fascinating because, for one, you see these patterns in people with dementia, as well as older people who don't have dementia, but it's very common for them to have, I guess you would call it sleep disorders. So my question is, how or what implications are being taken from the circadian rhythm work into the field of gerontology, both for those with and without various forms of dementia?
Well, this is a complicated, there's a lot of things to say about the question and the response, but I'll focus on one that comes to mind first. I think it is relevant to a degree. When I showed this slide about the circadian rhythms, how we would like it to be nice and, nice separation of the layers, so to speak, that I'm reminded of the joke we used to make about dermatologists. When I was a resident, I was a resident at NYU where they had this world famous dermatologist residency. And we would make fun of them and they'd say, well, this is what you need to know to be a dermatologist. If it's dry, wet it. If it's wet, dry it. So that applies a little bit to circadian rhythms. I don't know how much this works, but I do know that if people are not active enough in the daytime, I try to get them to be more active. And if they're not sleeping well at night, I try to help them sleep better. Sometimes, and this is interesting because in the geriatric group, some of these patients with MCI and mild cognitive impairment, few people are getting those drugs like Nuvigil or Provigil, which are these orexin-stimulating drugs that boost alertness. And some of those patients do get some cognitive enhancement from doing that. And then the next question from my point of view is, okay, so if we improve a person's alertness in the daytime, and they're a little more active and they're engaged cognitively and they're doing better in their cognitive engagement, do they sleep correspondingly better or do they not? Some of them do sleep correspondingly better because you get them engaged. Some of them still need further help because their sleep may have their own problem. The problem next is, the question is, can you give elderly people sleeping pills? Okay, and that's become a really big problem. I have a very close colleague who used to run a sleep lab at Columbia named Neil Cavey, and he is one of the patenters of Silenor, which is this very ultra-low dose doxepin, an old antidepressant, very sedating. And he actually made the patent for it because they would use it in their sleep lab. He would make a tincture of it, and then he said, okay, let's turn it into a pill. And so he was able to do that. Anyway, aside from that drug, which is great and generally well tolerated even by elderly people, he says benzodiazepines have been way overly maligned. Anxiety also, separate question, you didn't ask us about elderly people, but anxiety as a risk factor for dementia is quite high. And you could take people with ApoE who are at risk for, this was described yesterday, 70% risk of going on to develop Alzheimer's. If you take those people with antibodies against ApoE and you look at the ones who have comorbid anxiety and those who do not, it's like the curves go like this. So the people with the ApoE have anxiety makes them deteriorate cognitively over 3 years, prospectively. And then the people who don't have that, they don't do that bad compared to the people without ApoE. So that means a judicious use of some sleeping aid. It doesn't have to be a benzo. But I think the fear of benzos, there's concerns about falls in the elderly. There's lots of reason to be worried about it. I'm not saying I'll give it out freely, but there's a lot to be worried about if they're not sleeping well and they're really anxious. And there are a lot of other good treatments that are non-benzo treatments for anxiety as well, but I mean, you get my point. Trying to bolster their sleep, trying to bolster their waking, and keep them active is a way to, I think, manage some of that cognitive decline. Diabetic, pre-Alzheimer's or not. I said diabetic slipping, because there's a thought that Alzheimer's is like a type 3 diabetes. There's a model out there now, because there's some issue about the way their energy utilization is different, and they develop more insulin resistance over time, subtly, and then it affects brain energy. And one last little tidbit, orexin, which I showed you as sort of the master waking thing, that's also involved in metabolism. It's not solely a waking effect. Yes?
So, what are your thoughts about sleep deprivation that's not a result of necessarily these conditions, but say shift work or doing night shifts and things like that?
So here's a simple, that's a great question. I'll have my patients come into me and I'll say, how are you feeling? Oh, I'm feeling terrible. And they know this now, all my patients. I say to them next, well, how's your sleep? I go, I'm not done complaining about how bad I feel. I say, well, tell me about your sleep. I'll come back to complaining. But because I am so keen on what goes on with sleep, and it's not uncommon for someone to say, well, I only slept 6 hours last night, but doc, don't make too much about it because I had to do this or do that. And there's a very simple little logic about sleep that I try to educate my patients to understand. Sleep problems, short sleep on the one hand, where the patient doesn't complain like a bipolar patient, or insomnia where a person is fitfully not sleeping and really hates it. It's both a symptom of mental illness, but it's also a cause of mental illness. So it's an effect and it's a cause. And people don't like to think, oh, it could be doing two things at once, you know. But that's important to understand. So I will say to patients like that, so, well, when can we put an end to your, let's say, work demand that doesn't allow you to get sleep? Because you're looking for trouble if you continue that way, right? And the other thing that's interesting about, just to make one more layer more interesting, is that people, for example, who are overactivated and are bipolar will have all sorts of, I would call them cockamamie reasons why they have to be up. You know, they'll say, don't you understand, I was, you know, I had a party the next day and I had to stay up to 4 o'clock making piñatas. And I go, well, I don't know if you needed to make your own piñata, you can go buy one at the store. Anybody else?
Hi. This will be the last question, though.
I think there is a little bit of an irony between all of the research that has been done regarding sleep, because we all know how important it is, how it affects our mood. However, med students, residents, physicians are required to work in these crazy hours, and we are the ones telling the patients, hey, you need to sleep, but they're not doing themselves, and the regulations are not changing. So why do you think there is so much resistance to adopt something that seems so obvious and it has so much evidence in the workplace for doctors?
Well, my first answer is a lot of really smart people, like the administrators of medical school training, make really stupid decisions. You know, there was a move away. There was a brief period where they were moving away from these super long, you know, tours of duty, and the argument always back against that was that for continuity of care. A lot of the older residents would say, we really like the fact that I hung in there with Mr. Jones, you know, through a course of their illness development, you know, a heart problem, something that happens over the course of a day. And they thought there's a lot they lose if they treat it like a what's a simple word? You know, you're on a schedule, you know, whatever. So I think because of that, a lot of the residents started saying, I want to stay longer. Okay. And then they fell back and they went too far with it. So, yeah, I would say they shouldn't. There should be limitations to it. And also residents should be told, and this is an important thing, you need to recover sleep when you can. Because if it's an extraordinary situation and someone really, their life's on the line, and someone says, I'm sorry, I want to stay with them, then that resident should have some opportunity to catch up on their sleep as soon as possible.
You didn't put anybody to sleep.
I don't think I did.
Thank you very much.
It was a pleasure. Thank you.